it is my really great pleasure to introduce Dr. Mairead McNamara, who is a friend and former colleague. She is currently a senior lecturer and honorary consultant in medical oncology at the University of Manchester in the north of England, and also called the Christie. And she really specializes in this area of hepatobiliary pancreatic cancers and also neuroendocrine cancers. Early on in her career, she's been very successful with grants and research, and she's also a big international collaborator with emails going out to all of us constantly on projects. So I'm really looking forward to hearing her talk more on prevention and screening in cholangiocarcinoma. Thank you.
Good morning. As you'll know by my accent, I'm actually not from the UK, I'm from Ireland, and I feel quite at home, surrounded by green here. So I'd like to thank the organising committee for giving me the opportunity to speak here today, and it's an absolute pleasure to be in all of your company. So I'm going to talk about prevention and screening in cholangiocarcinoma, a little bit about the evidence and the challenges, and just there will be some overlaps with Jill's talk from previous, but that's unavoidable. Sorry, no, figure out what I to do with this. Okay, so these are my disclosures. And just any of my disclosures, there's no relevant conflict of interest to this talk. So this is just an overview of the talk I'm going to give today. I'm going to talk, and as I said, there will be some overlap. I'm going to give a little bit of background on it, the anatomical location of cholangiocarcinoma, a little bit about the incidence and the geographical variation for that. I'm also going to talk somewhat about the risk factors, and that's important when you're thinking about screening and what are the at-risk populations. I will mention screening then as well, and something about prevention, and what evidence is there and what the limitations are. So in terms of anatomical locations, and Jill has gone through this nicely as well, cholangiocarcinoma is a cancer of the bile ducts, and it represents about 3% of all GI cancers or gastrointestinal cancers. So the greatest incidence is found in patients in the 7th decade of life, and it's rare before 40, but it's not unknown. When you're thinking about risk factors as well for cholangiocarcinoma, actually for most patients, there's no particular risk factor aside from age. So in terms of frequency then, on the intrahepatics which are found within the liver, they represent 10 to 20% of cholangiocarcinoma, with the distal bile ducts representing 30 to 40%, and then the hilar representing approximately 50%. The worldwide incidence of cholangiocarcinoma is illustrated in this slide. And just to tell you as well that there are misclassifications in that bile duct cancers and cholangiocarcinoma can be classified differently in different countries. So this can't be exactly accurate. There can be underestimation and overestimation. But in terms of the colours here, cholangiocarcinoma, if it's a rare cancer, it's usually less than 6 patients per 100,000, and this is represented on the map by the green shaded areas. Then the red or pink shaded areas where it's a non-rare cancer, where there's greater than 6 cases per 100,000. And this is more often seen in the greatest incidence would be in Asia, specifically East and South Asia, and that's possibly due to liver fluke infection. So this was published just 2019, and this is just a prediction of the estimated deaths in 2019 from different cancers in the US. So you can see there for males, it's predicted to be the 5th leading cause of death at 7%, and females the 7th leading cause of death at 4%. So just to look on that graph, lung is top for both males and females, with prostate second for males and breast cancer being second for females. So treatment for cholangiocarcinoma is most effective for patients with early stage disease, but unfortunately only approximately 35% of patients are able to have potentially curative surgery. And then the 5-year survival is usually, for cholangiocarcinoma, is approximately 10%, with it being less than 5% for gallbladder cancer. So it's really important that we identify the populations at risk and also then have surveillance using effective screening methods if possible. So in terms of risk factors, Jill has gone through some of these already, and they can be broadly categorized into 4 different causative sections. When you think about inflammatory causes, there can be developmental abnormalities which lead to causes for bile duct cancer, environmental or metabolic factors, and also hereditary, as was mentioned previously. So inflammatory, if you just look at the images, the different things that can be causative would be bile duct stones, gallstones, hepatitis, primary sclerosing cholangitis or PSC, and also liver fluke infection. Developmental abnormalities can include things like bile duct cysts, environmental or metabolic factors such as smoking and diabetes, although obesity and alcohol have also been related. And then hereditary Lynch syndrome, for example, but again, there's a 2% risk of developing bile duct cancer if you have Lynch syndrome. So I'm just going to focus a little bit more on primary sclerosing cholangitis because this is important when talking about surveillance methods. So there is an increased risk of cholangiocarcinoma associated with PSC, and the estimated lifetime incidence is approximately 5 to 36%. So the potential risk factors in these patients would be older age, alcohol, smoking, and a longer history of diagnosis of inflammatory bowel disease before they were diagnosed with PSC. So the diagnosis of cholangiocarcinoma in patients with PSC often is incidental, as it is with a lot of patients with this diagnosis, or it can be detected possibly in explanted livers post-transplant. So this is another debate about, for patients with PSC, should they be having prophylactic liver transplantations? So this has been debated and it has been proposed, but it has been reported that a transplantation-induced mortality exceeds the risk of development of cholangiocarcinoma over a 10-year period. So the risk factors for cholangiocarcinoma can vary, as I said, across the world. And in Thailand, they vary slightly. There's a publication in 2018 from Thailand, and there was a strong association found between age and for liver fluke infection, eating raw freshwater fish, so carps and minnows, a family history of cancer, alcohol consumption, and using an agent which is used for treatment of parasitic worm infections. So the interesting things that they found here, the protective factors, were eating fresh vegetables and education. So education can be very important in this side of the world because you can educate about diet and the other risk factors that are involved. So when you're thinking then about screening, what is screening? What is the definition for screening? So the World Health Organization have given this, so it is a bit of a mouthful, but what they're essentially saying is that you identify a population, an at-risk population, so who have unrecognized disease. They're healthy asymptomatic, and by means of tests, examinations, or procedures that you can apply rapidly and easily to the target population. So you invite a population to take part in screening, you diagnose the disease, and you have a treatment available. So there are 4 processes that need to be in an effective screening program. 1, you need to be able to invite the people to participate. Over 70% of those who can participate do take part. That you repeat this over time and that it's effective at picking up the cancers, and then that there's regular monitoring and quality evaluation. So this is important for screening. So if you think about then applying this to cholangiocarcinoma, at the moment there are no surveillance guidance for early detection of sporadic cholangiocarcinoma or no defined recommendations in patients with PSC. So the different things that have been looked at and measured are things like CA 19.9 and CEA, but these have to be used in conjunction with patient factors, imaging, and potentially biopsy if required. And just to remember the limitations of following CA 19.9 or CEA is that CA 19.9 can be elevated in benign disease also. So if patients get infection or have cholangitis. And also not all patients will have raised CA 19.9, and that's because of their blood group that they may not express it. So there's greater than 10% of patients where the CA 19.9 won't be high. So the best evidence for screening in patients, specifically the at-risk, high-risk populations, the PSC populations, was a publication in 2011 where it was recommended surveillance with annual MRI, which is a type of imaging, or MRCP, or ultrasound, and CA 19.9. So this, if there was dominant strictures then identified, then they went on, they recommended then ERCP, where you could have a biopsy of this, the actual abnormality seen. So these surveillance recommendations are probably the best that are out there at the moment, but you would need to talk to your gastroenterologist or hepatologist about follow-up regarding this. It is probably the best that's there, but it's invasive and expensive. So then talking about prevention, so the two things I'm going to talk about is education and then particular agents, and Jill has touched on this already. But education is really important, especially in the high-risk areas like in Asia. So there was a publication from Thailand where they showed that there was an effective decrease because of education on lifestyle factors for these participants and patients. So this is just an example. I was in Cambodia in November this year, and just there are populations who live on the water, so they live in floating villages. So they drink the water, they wash in the water, the sanitation is all through the water. So education can make a big difference here. And then they eat raw fish. So on the actually on the right of your screen, this was just beside, we went to visited one of these houses in the floating villages, and they had just fish drying at the side of the house. So these are things where you can make a meaningful difference. So this is a study looking at aspirin and whether it has a chance of decreasing the risk of cholangiocarcinoma. So this was a study carried out in the Mayo Clinic, and it looked at patients. This was a retrospective study, so looking back at patient notes. So these patients included were between 2000 and 2014. So there was over 2,000 patients with cholangiocarcinoma, and then controls or people were looked at who were matched for age and for gender, and there was over 4,000 of those. So what they looked at here then was the prescriptions for aspirin over a year before the study was looked at, and they concluded that aspirin use significantly decreased the risk of getting cholangiocarcinoma, all three subtypes. But the caveat at the end of this study was that you have to be careful. This is a retrospective study. So in order to say whether this is definitive and has a definitive decreased risk of cholangiocarcinoma if you're taking aspirin, you would need to have a prospective study where you're looking ahead and getting exact details of what patients are actually taking. And I'm just going to, briefly go over this. Jill has mentioned it, and this was the publication on statin use. And this was from a UK database. And there was over 3,000 patients with biliary tract cancer included in this, with over 15,000 cancer-free controls. And what they saw was that there was a 2.7 to 3.6 fold there was a 12% decrease in the risk of getting biliary tract cancers in patients who took statins. And as Jill mentioned before, they weren't able to differentiate between the different types of statins. So these are just other topical things that patients often ask about. Vitamin D is something that's asked about a lot recently, and also cannabis. So the evidence in terms of vitamin D, this is a publication from New England Journal, and it was this month. And what they did is they included over 25,000 patients 25,000 participants in the US. And what they looked at was it was placebo-controlled, so half the patients got vitamin D and half didn't. They followed them up for over a 5-year period, and there was no reduced risk of cancer in the patients who had vitamin D. So this was just, it's a recent publication. The other thing that's quite topical is cannabis use and whether that has any effect. So when you look at the evidence that's there, the published evidence in terms of survival, there's no evidence yet in terms of survival and taking cannabis. The evidence that's there, and a lot is retrospective, is regard to pain control. And even the studies that look at pain control with cannabis, it said that prospective studies are needed. So studies where you go ahead, where you're following patients from now and you follow them and get a good history of what medications they're on. So the conclusions then from this talk on prevention and screening is that the incidence of cholangiocarcinoma varies, and there are lots of different risk factors. But for many patients, the only risk factor that's seen is age. So the treatment of cholangiocarcinoma is most effective when it's got early. So the focus needs to be on identification of populations at risk and then talking about prevention. So there are no surveillance guidelines to date. There are some guidelines that can be recommended for PSC, but you need to talk to your gastroenterologist or hepatologist about that. And then the strongest evidence, and this goes with the theme of collaboration, is if that you have large placebo-controlled studies, so placebo where you don't have active drug, and that you look at it in multi-institutional and you look at it multinational. So this is where the best answers will be. So if I was to give advice, I would say look at modifiable risk factors in terms of what you can do, lifestyle issues like smoking, alcohol, obesity, diabetes. If you go by the study from Thailand, eating fresh vegetables, education is important, and we can't change age. That's going to happen regardless. So thank you for your attention, and this is just a picture of the Peak District on New Year's Day in the UK, which is outside Manchester. So if you're ever interested in coming for the scenery and not the weather, it's somewhere nice to go. And thank you. So I'm happy to take any questions.
Hi, is this on? Yellow? You're on. Fred Kale, I'm a patient. Just a question, if anyone has any ideas of what appeared to me to be a mismatch on the incidence within the different types of cholangio between the worldwide statistics that you cited and I've seen elsewhere, and what appear, this is my second conference, and admittedly, even though there are a fair number of us, we're still a very small sample in the scheme of things, but it seems like most of us here are intrahepatic, and your data showed that worldwide intrahepatic was actually the lowest incidence of the three. How much of that might be geographic because of what's going on in Southeast Asia, or any other thoughts about what might be explaining why most people here have intrahepatic ICC?
Yes, so if you think about Asia, usually you think about the risk factors. Liver fluke infection can be associated with intrahepatic, but in the overall, the incidence where I give the map, so there has been problems with misclassifications. So when you're talking about the incidence, you're basing it on the information that's put into databases. So in different databases around the world, there's misclassifications so that some categories will include primary liver cancer, such as hepatocellular carcinoma, and intrahepatic. So you're not sure whether it's been overestimated or underestimated. So that may account for some. And intrahepatic seems to be rising, the incidence, but it may be that we're more aware of it now and that we're picking it up more, and that possibly patients who had it previously, it was put down to metastases of unknown origin, or that it was primary liver cancer, and possibly patients were not being biopsied and they weren't classifying it as an intrahepatic cholangiocarcinoma. Sometimes if you think of patients with primary liver cancer, not all patients were having biopsies previously. It was saying, oh, it looks like a primary liver cancer, so we'll treat it like that, and it was never biopsied. And possibly it was an intrahepatic cholangiocarcinoma, but we didn't have the histological evidence for that to support that. So whereas now we're veering towards everyone having a biopsy, because that's really important to know what exactly you're treating and that you give the proper treatment for that patient, because the outcomes may be significantly different. So it may be some of those that it may be staging, it may be identification, maybe biopsies, and it may be misclassification around the world. Okay.
Hi, good morning. Regarding the statin use and/or aspirin use, rather than just the incidence of contracting bile duct cancer, has anyone looked at patients who continue to take either drug and survival data?
Yeah, so we actually looked at that in Princess Margaret when I was there. But what you find there is that, so we looked at it in over 700 patients, and we didn't find any difference in terms of the survival in patients who were taking statins, aspirin, or metformin for diabetes. But it may be that the population was too small, and also you don't know how long the patients were on the drug, whether they're taking it regularly. So all of these things, when they're retrospective, there is room for a lot of error. So what you would really need to do is do a prospective study, and where you start at the beginning, the patients that come into you in clinic, and it may be that patients are already on the drug and that you can follow them from that time onwards and get more accurate results as you go along. But it's often you have to do like the vitamin D, that you have placebo controlled, and you have half the patients on drug and half on non-active drug, and it's only then can you say for sure this does cause this gives rise to better outcomes or not. So that's what's needed, rather than possibly looking at retrospective studies. So anything that's there is retrospective, and it's difficult to extrapolate from that.
If I could just quickly follow up on that, because we've been interested in that same question. So we were looking in the CPRD data, the same data that the statins and incidence comes from. We found that statins and CPRD was not associated with any difference in survival once you have cancer, but aspirin, we do seem to see a reduced risk of death. So like survival is improved. Mostly kind of the baby aspirin dose, yeah. Very few people taking higher level doses. But I do want to emphasize that this is, although we're looking at people who have cancer and then following them, this is not the same as a clinical trial. So we are really trying to dig in and understand, is there something about people who take aspirin that may be different, and that might explain the effect rather than an actual effect of aspirin. We're not sure, but it's a great question. We're digging into it.
Sorry, I just have a comment because, the statins have benefit in terms of anti-inflammatory, and then metformin also has data for cancer and whatnot. But the actual thing is, I think it also comes down to, again, patients' mutations, because I think when I was looking up metformin, that metformin might have an IDH1 inhibitor type effect, and then it becomes then, I think a lot of people were thinking IDH1 inhibitors might actually be beneficial, but then there was some other literature that I was reading that it actually may be that it increases abrachiousness and actually makes you more sensitive to chemo. So I think that it makes studies very hard, or to look at those population studies, because...
Yeah, and what I would add there, I suppose, as well, is with the IDH mutations, just these are predominantly in patients with intrahepatic cholangiocarcinoma. Intrahepatic cholangiocarcinoma is 10 to 20% of those with cholangiocarcinoma. So it's hard to say that it's, for that population, it gets smaller and smaller than if you're doing prospective studies.
Yeah, I thought it was very interesting, though, today when they surveyed who was here and what type of cancers, actually it was mostly ICCs that were here.
Yeah,
so.
I suppose the other thing to think about there is potentially even though they say that the survival is similar for all patients with cholangiocarcinoma, it may be slightly different for patients who have mutations where there's more treatment options available. And also for the other types of bile duct cancer, often there's more problems with cholangitis and infections, and sometimes it may be that it's like a little bit biased and the population that are able to attend are able to attend, you know, because they don't have the other things like infection.
We have one over here. Can you stand up? Last one, can you stand up?
Hi, how are you? I'll make it quick. I appreciate the presentation and I know there's the environmental factors and different things, the obesity and other things that they're finding links. Have you guys done any specific research on possible like mutations in genes that are causing more incidence of the cancer? The reason I bring it up is I know that with mutations in TBX3 gene, there's an increase in breast cancer, is from what I've read. Especially with ours, my wife has an increase in overexpression of TBX3. And in fact, just a fun fact, that actually led us to be able to finally determine the name of a birth condition that her and my daughter have. So has that been something that's been studied as something to look at? I know genetic mutations are great in treatment, but are there any genetic mutations that you've linked to this type of cancer?
Yeah, so this has been looked at where you're looking at the profiling or what it looks under the microscope and what the genetics are related. And with bile duct cancers, the big things are probably things like in pancreas cancer where you have KRAS, TP53, so that you have a mutation in the tumor suppressor gene. So we do know that those mutations are associated with a lot of bile duct cancers, but the problem is that there's nothing to treat that yet. There are no agents available to treat the TP53 mutations necessarily or the KRAS mutations yet, but it doesn't mean that that won't be a possibility in the future. The IDH mutations are associated with intrahepatic, and the FGFR mutations have been found in intrahepatics as well. So we know now there's agents to treat. We don't necessarily, with the FGFR, it may be that having that mutation has worse prognosis in terms of survival if you don't have the active agent. But we do know the mutations that are there, but there isn't something necessarily to treat, or there isn't the surveillance or evidence there to follow those patients. You know, there are some who would be followed up because of a different genetic condition, but not necessarily they wouldn't have been picked up for unless they were on a follow-up with a family of a particular genetic condition. Okay, thank you very much.